We are here at Giornate Cardiologiche Torinesi, 37ª edizione. It's my pleasure to be here with Dr. PANOULAS. He is the interventional lead for Harefield and Brompton Hospitals in London, UK. And he has also been one of the co-authors and investigators of the Danger Shock trial. So the Danger Shock trials is the first trial showing a prognostic effect for a treatment in cardiogenic shock MI in 25 years. Specifically, the trial revealed that a microaxial flow pump is able to reduce mortality at 6 months in cardiogenic shock with a very positive number to treat of 8. So we need to treat 8 patients to save 1 life at 6 months. But at the same time, the trial demonstrates the biological cost of this device. Specifically, this device is associated with complications and with a complexity of management. So in order to improve the benefit of this device, patient selection will be pivotal. Dr. Panoulas, what the sub-analysis of this trial are starting to teach us with this regard?
Yeah, as you mentioned, it's one of the first trials that shows us a positive result of a microaxial flow pump. And we were quite enthusiastic that these results were also sustained in the longer term. I think this was the results published last summer. In terms of sub-analysis, because obviously when it comes to implementation in different countries and cardiogenic shock programs, everyone wants the best efficiency with the less cost. And the sub-analysis showed some very clear trends. They show that, for example, if we use a device for people younger than 77 years, you would see a number needed to treat going down from 1 in 8, to 1 in 5. And in fact, if you look a bit closer, middle-aged people in the 40s, 50s, 60s, that number would go down to 1 in 4. So I think that's one important message, and probably the reason for that is that in elderly people, the complications counter the positive effects of the device, as you mentioned. Then also we realize that there is a time-sensitive issue. The faster the device goes in cardiogenic shock, probably you avoid the spiral and then you manage to save more lives. And of course, that might not be very easy for operators to accept in recent days because everyone is a bit obsessed with the door-to-balloon time. But I think there have been very major studies in New England Journal of Medicine that show that there is a limit to how low you can bring the door to balloon and there's no impact on mortality. So I think we need to think a little bit different and start thinking that we might be able to improve our survival just by using the device up front and as quickly as possible. Of course, that brings also logistical issues for different areas because patients have to be transferred in shock centers that have the availability of the device. But that is something that will be discussed in every shock network in the long run.
So basically, some more work to do. We are starting to understand who will benefit the most from these devices, and this is the right direction to go.
Absolutely. And then, there was also another study that showed that patients that present with shock and also a bit lower blood pressure, even lower than systolic of 80 millimeters of mercury, show a very big benefit. But I think that also has to do with the inheritability of the pump to basically pump more blood when it works with lower pressure differentials. So this is something to just think about, food for thought. But I think in terms of implementation, in my experience, it seems that if we apply to patients under the age of 80, and also if we are faster in our response time, both the paramedics that bring the patients to the hospital and the hospital teams, we will achieve much better results in the long term.
Thank you. I think this is very interesting. So I actually have a second point I'd really like to discuss. The microaxial flow pump, the Impella pump, has a big rationale regarding myocardial preservation. And this kind of rationale can be intuitively applied also in patients with MI without cardiogenic shock. What are the evidence that we have in this field and where are we going?
And this is a very interesting field, and it has to do with the theory of unloading, basically trying to release energy from the heart, the sick heart, so you allow time for it to recover. And experiments on animal models have been going on since the 70s. And when they first observed that effective unloading can reduce ST elevation and reduce myocardial infarct area. Obviously, clinical data yet are lacking, but we are quite excited also to have been part in the STEMI-DTU trial, which will be hopefully announced in ACC this year, and then we will find out the results. But obviously, the STEMI-DTU trial was designed for patients that are not in cardiogenic shock with a traditional definition, although I think we found out that some of them had a slight elevation of their lactate and probably are falling into that Sky B category that we think. But I think that's one very exciting piece of randomized evidence to be waited for. But obviously the big question is, will the benefit be able to counter the effect of the complications that we inevitably will be causing with the device? And I think moving forward, what we and the industry have to work together to make the pump smaller so we avoid the vascular complications, deal with the issues of hemolysis, of optimal pump position, and everyone has to basically focus really much on best practices.
Like, I would say with every new technology, you need to start knowing how to use it, improve, reduce the residual risk of the complications of this technology, improve the technology, and then we can leverage on the physiopathological benefit that we are starting to observe.
Absolutely, because as with everything, it's a tool. A hammer is very nice to use to put a nail in the table, but also you can break someone's head. So I think if you go past the learning curves and you apply best practices, then you will enjoy the best benefit of the pathophysiology that the pump will provide.
Thank you, Dr. Panoulas. I think it was a great talk.
My pleasure.